Hello friends, in my last lecture I have dealt with the clinical features of prostatic cancer and also started the diagnostic aspects of prostate cancer. In that, when the person comes to you with an incidental finding of prostate cancer or with the symptoms of prostate cancer, then you will have to do a rectal examination. Then in the rectal examination you will feel irregular induration, stony hard part in a part of a gland or in the whole gland. So that suggests prostatic carcinoma. And then once you have done the prostate examination and you know that there is something wrong in the prostate going on, then you should do prostatic biopsy. So how do you do a prostatic biopsy? Here, this is the penis and then scrotum, okay, and then this is the anal opening, this is the thing, okay, anus, and then this is the rectum, anal canal and rectum, okay. And now this is the penis. So if I have to draw the this one, this is the urethra, and then this is the urethra, and then you will go like this, right? And then this is the bladder. And where is the prostate? This is the prostate, right? So now this prostatic biopsy is done transrectally. So this is the rectum, through anus and rectum you will go and then you will take a biopsy. So this is done transrectally. Using an automated gun. Okay, it is done transrectally using an automated gun. Your local anesthesia can be given to decrease the pain. Local anesthesia is given to decrease pain. Okay, generally we take about 10 systemic biopsy course plus biopsy in any suspicious area. Okay, this is what is done. Always give broad spectrum antibiotics to prevent sepsis because you are going through transrectally. So whenever we do something transrectally, there is a chance of increased sepsis. So you give broad spectrum antibiotics prophylactically. So this is prostatic biopsy which you do after rectal examination. And then once you get the prostatic biopsy results, histologically you can classify it based on Gleason score. And then you do general blood tests. So in blood test, whenever there is metastasis, you see anemia, that too leukoerythroblastic anemia. And then you see, number one, you see two types. Anemia can be of two types. One, general anemia. This is due to renal failure. Whenever there is renal failure, no erythropoietin, decreased erythropoietin resulting in anemia. And the other, leukoerythroblastic anemia, is due to metastatic marrow invasion. Because bone is the first site for metastasis, so marrow invasion may lead to leukoerythroblastic anemia. Okay, and then there may be thrombocytopenia. And then you can do liver function test for liver metastasis. there is increased ALP seen whether in liver or bone invasion. But how do you know whether it is liver or bone? In liver, there is increased gamma glutamyl transferase. Okay, this shows that there is liver metastasis. Okay, and then you can do acid phosphatase. Also, and then these are the major tests, and then you do radiological examinations. What radiological examination you do? In radiological examination, number 1, you do chest X-ray for chest metastasis, lung metastasis, and also ribs metastasis, because it first primarily involves bone. And then you do abdomen X-ray for lumbar and pelvic bone metastasis. So basically here bone becomes dense and coarse because of sclerotic lesions. But rarely sclerotic plus osteolytic lesions are seen. Okay. Ultrasound for metastasis to bladder and others. MRI for staging local disease. You can also do transrectal ultrasound, which is TRUS. Okay, next, bone scan. For staging, if prostate specific antigen is more than 10 millimoles, 10 nanomoles per liter. But if less than 10 nanomoles per liter, done only on clinical indications. For bone scan, we inject technetium 99M, and this is monitored using a gamma camera. Okay. Finally, you do lymphangiography. And you can also do bone marrow aspiration. Whenever bone marrow aspiration is done, it reveals bone marrow, metastatic cells. What is the way to explore? Like, how do you screen? After screening, how do you go about with prostate specific antigen? So what I would like to tell you is what is the approach for prostatic carcinoma. How do you approach? Rather than all these, how do you truly approach prostatic carcinoma? This is through prostate specific antigen, right? So how does prostate specific antigen help us? That is really important, right? So once on screening, we screen for prostate specific antigen. There are 4 major things which show. Prostate specific antigen can be 4 nanogram per milliliter or 4 to 10 nanogram per milliliter or more than 4 nanogram per milliliter. Okay, more than 10 nanogram per milliliter. If it is 4 nanogram per milliliter or less, then it is negative. Okay, then do digital rectal examination. This is important. Digital rectal examination. This is basically negative. Do digital rectal examination. Even this is negative. Then you do annual follow-up. Right? If this is there 4 to 10, we have suspicion that it may be prostatic carcinoma. So digital rectal examination is done. If negative, then biopsy. Okay. If more than 10, then you do digital rectal examination. Is not recommended basically, because even if it is negative or positive, in both cases you will have to do transurethral ultrasound plus biopsy. Right? This is transurethral ultrasound because I get confused with shortcuts, which is TRUS, is transurethral ultrasound. So in both these cases, if it's positive, then you will have to do biopsy plus transurethral ultrasound. So this is the approach which you undergo for prostatic carcinoma whenever PSA is done as screening test. Now, treatment of carcinoma prostate. So, early disease. Okay, so first, early disease include T1A, T1B, T1C and T2. So first let us learn about T1A. So this is found incidentally, right? Incidentally it is found by transurethral resection of prostate. And it is well differentiated in Gleason score. So what you do in this stage is active surveillance with 3 to 6 monthly digital rectal examination. Every 3 to 6 months you should do digital rectal examination, that is DRE. Plus prostate specific antigen measurement. And then if after many days there is disease progression, then we will have to treat it, or else there is no need for treatment. That is done for T1A type of carcinoma. Then if T1B, T1C, T2, then we will have to see patient's age, performance status, and then lifestyle preferences. And based on it, you should treat. That is T1B, T1C and T2. If it's T3, T4 or any M. Then do palliative. You can't do anything other than this. Right? So this is what you do for prostate carcinoma. Right? So what are the treatment options available? Treatment options. Number 1, radical prostatectomy. This is only for localized disease, not for the extended one. T3 is extended to seminal vesicles and bilateral extension, whereas T4 is metastasis. So we don't do radical prostatectomy for T3 and T4. This is done for T1 and T2. And it is done in men with life expectancy more than 10 years. And then exclusion of metastasis. By negative bone scan and then chest X-ray should be normal. There should not be any metastasis. And then serum prostate specific antigen should be less than 20 nanomoles per milliliter. Okay. Here in radical prostatectomy, we remove prostate to distal sphincter. Let me draw a diagram. That is better. Diagrams are far better in understanding rather than anything else. So this is the prostate and this is here, the external one. So you will remove it from the prostate to the external sphincter along with the seminal vesicles. So you remove prostate to distal sphincter plus seminal vesicle. Till here, not till here, only till the sphincter. Okay, and then you anastomose bladder neck to urethra. We can do it either by open or laparoscopic or robotic. The procedure is same but the method may be different. That is radical prostatectomy. Either open or laparoscopy or robotic. But the procedure is the same. We'll have to remove the prostate till the distal sphincter and then seminal vesicle. And also seminal vesicles. From varium internum, we remove the seminal vesicles because that is seminal vesicle spread. Then anastomose bladder to the urethra. That is radical prostatectomy. And then you can give second type of therapy which is available is radical radiotherapy for any cancer, any prostate cancer. For early prostate cancer. In this we have external beam radiotherapy. In T1 and T2, surgery is better than radiotherapy. Because in radiotherapy, 30% remnant disease is seen through histology. So mostly surgery is better than radiotherapy. So mainly this is used for T3 locally advanced disease. That is T3. Okay. For 4 to 6 weeks we'd use it. Vachestunna. 2 minutes last. Brachytherapy. This is one more type. In this, brachytherapy is internal radiotherapy. In this, what we do is, so this is the penis, this is the thing, and then this is the rectum part, right? So this is the my urethra, and this is the thing, and then this is the bladder, and these are the prostates, and this is the rectum. So what we do is, we go transurethral and we place the radiotherapeutic material here. So here under transrectal guidance, not transurethral, transrectal guidance, under transrectum, this is rectum, so transrectal guidance, we implant radioactive, not here, it's in the scrotum, I'm sorry, it's in the prostate, I'm sorry, radioactive seeds implanted in prostate. Okay. These are inserted through perineal needles. I'm sorry. What we do is, I really forgot about this. Yeah. What we generally do is, we will first, through transrectal, we keep a probe. And we do an ultrasound first. Transrectal ultrasound. And then, this is transrectal ultrasound, okay? And how do we implant it? We keep a perineal needles. So, yeah. This is a perineal needle. Through perineal needles, we will implant these seeds. These seeds are implanted through perineal needles. These are the perineal needles. Okay. All this is done in lithotomy position. So this is brachytherapy. Here the radioactive seeds, what does that belong? The radioactive material includes iodine 125 and palladium 103. It is used widespread for low grade T1 disease. This is use. And what is the advantage? Decreased per operative complications. Generally in operation we can have complications, but here there is decreased per operative complications. And low morbidity. The patient has good lifetime during the course of therapy too. Then what do you do in advanced disease? Let me first brief again about this brachytherapy because I said wrong first. So what you do is, this is the rectum, this is the bladder, and this is the urethra. So what you do is, you pass a transrectal ultrasound probe and then take an ultrasound. And through ultrasound guidance, we pass perineal needles from the perineum into the prostate. And in the prostate, through these perineal needles, the radioactive seeds are implanted. So this is what happens in brachytherapy, right? And then advanced disease. In advanced disease, what we can do is androgen deprivation can be done, because it is mainly due to increased androgen. So androgen deprivation by hormonal therapy. Okay, this can be done in advanced disease. And then you can do orchidectomy. This is done in locally advanced, that is T3, or metastatic disease, that is T4. In that we can do orchidectomy. And medical castration. This is done by silbesterol or luteinizing hormone releasing hormone agonist. LHRH is luteinizing hormone releasing hormone agonist. These will inhibit testosterone. What these do is LHRH agonist. These will activate hypothalamic LHRH receptors continuously. Generally, LHRH should be in pulsatile form. LHRH normal release is pulsatile. But because it stimulates continuously, so there is continuous LHRH, which will decrease pituitary LH production, thus decrease testosterone. Right? So this is what happens here. So if LHRH agonist is given in first 10 days, testosterone increases. So we give flutamide, which is testosterone inhibitor, or bicalutamide or cyproterone acetate during this period for 10 days. For 10 days we give this. And then LHRH agonists, these are given for monthly, or these are available as monthly or 3-month depot injection. So they can be given in any way. Okay, now complete androgen blockade. This can be done by orchidectomy or LHRH therapy or androgen receptor blockade. This is by flutamide or bicalutamide or cyproterone acetate. And then you can give general radiotherapy. This is best palliative. Best palliative treatment given for up to 6 months. Strontium can be given. Strontium 89. Okay. Then, chemotherapy can also be given. Okay. These are the final therapies which we do for prostatic cancer. Thus, the topic prostatic cancer is over. In our next class, I will start with a new topic again. Thank you guys for watching my lecture. I hope you understood the topic. If you want some help in other topics, you can comment in the comment section. If you feel something is inadequate, even then you can comment in the comment section. Thank you for watching my videos. Thank you.